And the idea that we think we can create a health insurance company, whether it be co-ops or otherwise, that are going to be more efficient than including profit, than the average health insurance company is poppycock. Because when you really look at the real costs of Medicare and Medicaid, their true overhead costs are about 25, 26%. They're not the 3 to 6% we quote all the time, because we never consider the cost of capital. There's no profit in it. And then which was misquoted by Senator Alexander, the hearings that we've had in the Oversight Committee, is Medicaid's at least $40 billion now, and we know from GAO that that's a hard underestimate of the amount of fraud and waste in it. And Medicare's at least $80 billion. So when the assumption is that we can do it better, you know what? We can't, and we won't. And we can pass this bill, and what we're going to have is another headache because we thought we could do it better than the way we do everything else in this country, is truly allowing forces to allocate scarce resources. Senator Harkin cares immensely about prevention. I do too. We don't get out of this unless we fix prevention. But us deciding how to fix prevention is a whole lot different than what a Steve Byrd has done at Safeway. And we will mess it up because we don't have all the knowledge and we don't have the right motivation, which is healthier, happier, longer living employees paying less money. What we'll have is a program. So Senator Harkin's intention, his heart is pure. But will it be efficient? Name me one efficient, effective federal government program that we've set up. Name one that's efficient and effective. A pilot's effective. We put him in an F-18. But is the Pentagon efficient? No. And we have that all across the federal government. So if our answer is we've got the answer and we're going to tell everybody else how to do it, I can promise you right now we're going to fail. And I don't think we should fail. It's too important. We have big problems in health care. And we need to come together based on what the real facts are out there, not our personal biases, and see what is working and how do we incorporate what is working. The second principle that I would bring forward is the states are doing all sorts of different things right now. Whether it's Massachusetts or Utah or Rhode Island, why would we want to limit progress in terms of what they're doing? We heard talk about low birth weight babies. You know why we have low birth weight babies in this country? It's because we have Medicaid that pays about 35% less for a doctor to care for an indigent woman than for another doctor. Well, guess who ends up caring for most of the Medicaid? Out of the 4,000 babies I delivered, 2,500 of them have been Medicaid. But what happens is that shifts down. And so what we promise in terms of care and coverage is just a promise. It's hollow. Because they don't get equal coverage. They don't get the same care. They don't get the same attention. And yet we've promised it to them, but we don't deliver it. And the reason we don't deliver it is because we don't put the resources behind it. Because we're living within a budget. And we ignore market forces. Markets aren't the total answer to this, but there's some. We'll never solve the problems in health care till we reconnect the purchase of health care to some small amount of economic pain with the person that's making the decision receiving the health care. You can deny that all you want, but everything else in our country works that way. And as long as we ignore that, we ignore it to our own peril, even with a government plan. You know, we're taught in medical school 3 basic tenets. And it'd be wise for this committee to pay attention to them. And the first is listen to your patient, and every time they'll tell you what's wrong with them. If you listen well enough and ask the right questions, they'll tell you. Well, we haven't done enough listening to everything that's going on out there. And we're also, when we listen, we're not hearing. Number 2, if it's been done already and isn't working, don't do it again. We're getting ready to do it again. And the third thing is don't do any harm. We truly have 1/6 of our economy that we're talking about now, and we have no idea what the long-term ramifications of what we're talking about doing in this committee is going to have on that economy. We think we do, but we don't know. And so we're throwing the dice for what we want, but we haven't listened to the patient, and we're doing things that we've already done that don't work very well. All you got to do, the $39 trillion on Medicare is small. A child born today in this country owes $400,000 in benefits they're never going to receive a thing from because we've not done what we should have done in Medicare and Medicaid and Social Security. And we're getting ready to create something new. I'm all for working with all of my colleagues, both sides of the aisle, but we ought to do it on what the real facts are out there and what we have learned. We know that if we incentivize prevention the proper way, that we'll get a ton of savings. And we also know that if we don't do that in terms of the management of chronic disease, it doesn't matter what we do. We can do what Senator Sanders wants and we can create an absolute single-payer system. But you know what? The costs aren't going to go down unless we incentivize the management of chronic disease. They won't go down. They'll continue to rise because disease prevention is the way we get out of this. And unless this bill has that as its primary focus, the sustainability of it, the getting out of this problem, we won't cut the 7.2% inflation rate in health care, especially with the demographics of people aging. Sheltering children, as Bob Casey said, that's important. And we just modified S-chip and rejected a Senate amendment that would have covered all those kids and not raised taxes at all. And yet we got 16 million kids out there today that are eligible for S-chip and Medicaid, and they're not on the roll. Why? Because we're not listening to the patient. We're not listening to what we're doing wrong, and we're getting ready to make the same mistake again. 16 million of them. And so why are ERs loaded with kids with an ear infection when they're already Medicaid eligible? Because we haven't oversighted, and neither have the states, in terms of enrolling those people to where they have a primary care. And we have a Medicare payment system that says if you're a medical student graduating this country, you don't want to go into primary care because there's a 300% payment differential versus you spending another year or two in training, you'll make 300% more. So only the most altruistic of our physicians go into primary care. It's obviously not about money because they could be an engineer and make twice as much with less time and a lot less school debt. So I would just ask my colleagues is, as we walk down this, I agree to walk with you to truly fix the problems. Senator Mikulski and I have a totally different look at cost comparative effectiveness. I'll tell you the other reason I think health care in this country is pretty good. And it's good for my Medicaid patients and my patients that don't have any health insurance. Because when somebody gets cancer, most of the time we get them well. Most of the time we get them well. Some fall through the cracks. That's true. But as a two-time cancer survivor, I think this health care is pretty damn good. I think it's pretty dang good. I have atrial fib. If we have what Dr. Mikulski wants to do on comparative effectiveness, I've been through 7 medicines trying to get it controlled. But if we follow comparative effectiveness, I'd never got to the 7th medicine. It had just been tough. I'd been on digoxin, take Coumadin the rest of my life, and run around with atrial fib, which would cut my life expectancy about 7 years. We're not going to ever consider that because comparative effectiveness denies the art of medicine. It denies that we will use Chairman Dodd's gray hair, somebody's long-term education, their wonderful years of experience, and the history of that patient with which to make a decision that is best for that patient, not which is best to save the government money.